Welcome to the Smith+Nephew digital education module on the T of T.I.M.E, non-viable or deficient, which forms part of the T.I.M.E series you can access to develop your knowledge and understanding around wound care. By the end of this module, you will be able to understand what non-viable tissue is, how non-viable tissue should be assessed, and recall methods of debridement and how they're used. For this section, we'll refer to the T in T.I.M.E, tissue, non-viable or deficient. The goal is to assess for and identify the type of non-viable tissue and establish a plan and goals for management. The presence of granulating tissue suggests a healthy healing wound. It's important to note that it can either be healthy or unhealthy tissue. Healthy granulating tissue is characterised by its red, pink, granular appearance, which is due to a network of newly formed capillary vessels and mainly comprises of fibroblasts, collagen and blood vessels formed through angiogenesis. Signs of unhealthy granulating tissue can be seen as hypergranulation or excessive vascular tissue. There can be bleeding or friable granulating tissue, epithelial bridging and pocketing in the granulating tissue. There are typically two primary types of non-viable tissue found in chronic wounds, including slough and eschar. Slough is usually yellow or tan and may be moist, mucus-like or stringy and fibrinous. Slough is often a mix of fibrin, degraded collagen and devitalized tissue. Eschar or necrotic tissue represents deeper soft tissue damage. It's usually black, brown or grey. Eschar may be moist, soggy or dry, leathery, hard or crusty. Slough and eschar are often documented as a percentage of the wound bed. The presence of non-viable tissue is a barrier to wound progress. So how do we manage this barrier? The first step to wound bed preparation is cleansing the wound and surrounding skin to remove debris, loose non-viable tissue, microorganisms and exudates. This may be accomplished with normal saline, commercial cleansers or in some cases sterile water. The aim of the wound bed preparation helps create an optimal wound healing environment by producing a well vascularised, stable wound bed with minimal exudate. A wound with non-viable necrotic tissue will remain in the inflammatory phase of healing. Debridement, the removal of non-viable tissue, is the intervention which plays an important role in wound bed preparation and progress. In addition to improving wound visualisation, debridement removes bacteria, reducing the risk of infection and reducing wound odour. Ultimately, debridement promotes an environment for wound healing. It's important to note that debridement is contraindicated for non-infected lower extremity wounds related to arterial insufficiency. These wounds have limited blood supply to support healing. Additionally, debridement should not be conducted on intact eschar on the heels of non-ambulatory patients. Let's discuss some of the most common debridement methods. Debridement methods fall into two categories: selective debridement and non-selective debridement. Selective debridement can be autolytic, enzymatic, larvae or conservative sharp debridement. Non-selective debridement can be mechanical, surgical or high-pressure irrigation. The choice of debridement methods for a wound will be determined by a number of factors such as wound condition, patient's needs and available resources. Autolysis or autolytic debridement involves the body's own white blood cells and natural enzymes to remove non-viable tissue while leaving healthy tissue intact. During the inflammatory phase of healing, autolytic debridement occurs naturally in patients with inadequate leukocyte function and moist vascular wounds. Autolysis is slow and therefore not ideal for infected wounds. Any dressing that will maintain a moist environment can help to promote autolytic debridement. Enzymatic debridement involves the application of topical enzymes to remove necrotic tissue from the wound, a faster debridement method than autolysis. Collagenase selectively removes necrotic tissue by digesting the collagen where it is attached to the wound base and does not harm the granulating tissue. Maggot therapy is a type of biotherapy involving the application of live disinfected larvae to the non-healing wound bed. The larvae are produced by the green bottle blowfly. They are necrophages, which means they selectively debride the wound bed by only feeding on dead and devitalized tissue. Proteolytic enzymes are secreted by the maggots into the surrounding environment. The enzymes help dissolve the wound eschar and slough, which is then ingested by the maggots. Maggot secretions are known to have a broad spectrum antimicrobial activity, and a metabolic byproduct of the maggot is ammonia. This has been known to alter the pH of the wound, preventing recolonisation of bacteria. Larval therapy has the ability to rapidly and selectively debride a wound. However, not all patients and clinicians are receptive to the therapy because they think it may be distasteful, and due to the higher unit cost may be considered expensive compared to other selective debridement options. Conservative sharp debridement includes the use of sterile instruments to remove loose adherent necrotic tissue. No bleeding is expected as only non-viable tissue is removed. Conservative sharp debridement may be performed only by qualified clinicians. Some methods of debridement require specialist training. Check your employer's policies and procedures in relation to the debridement procedures you are allowed to perform. Monofilament debridement pads contain a large number of polyester fibres of a specific size and thickness. Depending on the area being treated, use the soft, fleecy side of the pad to apply a gentle cleansing action to the wound and surrounding skin if indicated. A separate pad must be used to treat different wound areas. The microfilaments lift debris without causing damage to the area being treated. The monofilament pad has been noted for its ease of use and well tolerated by patients. Surgical debridement is almost always conducted in the operating room or special procedures area with the patient anaesthetised, and is performed with a scalpel, laser or hydrosurgical device. While surgical debridement is considered non-selective debridement, hydrosurgical debridement allows the surgeon to debride while sparing healthy tissue. Faster than other methods, surgical debridement is usually the method of choice to remove large areas of necrotic tissue or for wounds with progressing cellulitis, wound-related sepsis and/or infected bone or hardware that must be removed. Risks associated with surgical procedure must be taken into consideration, including anaesthesia, bleeding and infection. Surgical debridement must be performed by a surgeon or an advanced practice clinician, such as a nurse practitioner or physician's assistant, trained for surgical debridement. To check your knowledge and understanding, try and answer the quiz questions. Why is wound measurement important? It indicates rate of healing and indicates if the wound is static, healing or deteriorating. What are the commonly used terms of tissue types? Necrotic, slough, epithelial and granulating. What are the types of debridement? Mechanical, autolytic, enzymatic, larvae, sharp conservative, surgical debridement. Well done! We have now completed this bite-sized module. Take the time to reflect on how you will take some of what you've learned and apply it to your daily practice. Please click on the link to go to the full 15-minute version of this presentation. Once this is completed, you will have the opportunity to download your NMC revalidation certificate. Thank you for your time today. Please remember to look at the other sections to access additional modules to help you on your learning journey.